Welcome back to Decode Healthcare with Harshal. Today, we're jumping right into part 55 of our 100-part ICD-10 CM Guidelines series. We are deep into Chapter 15, folks, Pregnancy, Childbirth, and the Purporium. Specifically, we're unpacking section IC15G and Q of the CMS Guidelines. So grab your coding manuals, because in this explainer, we are mastering ectopic pregnancies, molar gestations, abortion classifications, and the notoriously tricky Category 008 complication sequencing. Let's get into it. Here is our quick roadmap for today. We'll start with Chapter 15 Priority, move into ectopic and molar pregnancies, break down the abortion categories, and finish up with 008 sequencing. Okay, first things first, we absolutely must establish supremacy here. Based on the CMS guidelines, Chapter 15 codes always, and I mean always, take sequencing priority on the maternal record. Obstetric cases require codes from the 000 to 09A range, and they literally override codes from any other chapter. The only exception, well, that's if the provider explicitly documents that a condition is entirely incidental to the pregnancy, which is when you'd use a Z33.1 code. Otherwise, Chapter 15 rules the claim. Getting this backward is pretty much an instant path to a denied claim, so keep it top of mind. Right, moving on to our first major restricted zone, ectopic and molar pregnancies. So there's a very clear clinical distinction between these two abnormal, non-viable gestations. An ectopic pregnancy, which falls under Category 000, happens when a fertilized ovum implants outside the uterus. On the flip side, a molar pregnancy, specifically a hydatidiform mole under Category 001, is actually a non-viable tumor of the placenta that secretes hormones. Since neither of these are viable, they require very specific code assignments that look totally different from your standard delivery codes. To capture those ectopic pregnancies accurately, your code choice has to reflect the exact anatomical site of implantation. We're talking the fallopian tube, the ovary, or the abdominal cavity. For instance, assigning code 000.12 tells the payer a very specific, detailed story. It says a tubal pregnancy implanted in the fallopian tube and then it ruptured. Remember, the more precise the clinical documentation, the more precise your code needs to be. Now, here's the absolute golden rule. Because ectopic and molar pregnancies are non-viable gestations, standard outcome of delivery codes are strictly forbidden. The guidelines explicitly dictate that Z37 series codes, the ones indicating the outcome of a delivery, like a single live birth, are never, ever assigned here. If your billing software tries to append a Z37 delivery code to an 000 ectopic code, that is a hard stop. Do not pass go. Next up, let's shift gears and talk about classifying the different types of abortion. We really need to differentiate the clinical mechanisms here because they matter for your codes. A missed abortion, coded under subcategory 02.1, is an in utero fetal death that happens before 20 completed weeks of gestation. But, and this is key, it's retained without spontaneous expulsion. Basically, the body hasn't recognized the loss just yet. Contrast that with a spontaneous abortion, category 03, which is a naturally occurring miscarriage before 20 weeks, where expulsion has either started or completely finished. And a quick heads up for 03. You must always specify if it's complete or incomplete, and whether it's complicated by something like a hemorrhage. Think of this breakdown as your foundational cheat sheet for the 4 major clinical types of abortion. 02.1 is your code for the missed abortion, while 03 is for the spontaneous abortion. Then we have category 04, which covers an encounter for an elective termination of pregnancy, meaning a legally induced termination. And finally, category 07 is for a failed attempt at abortion, which is an unsuccessful attempt to terminate. If you master these 4 baselines, your core coding is going to be absolutely flawless. When you're digging through a medical record, just use a little logical deduction to land on your base category. If fetal death is retained at less than 20 weeks, boom, you're at 002.1. If a spontaneous miscarriage happened naturally, you route straight to the 003 series. And if it was an elective termination, route right over to 004. Once you nail down that primary branch, then you can start hunting through the chart for any secondary complications, like retained products of conception or an infection. All right, time to test your guideline knowledge real quick. We just talked about delivery codes a moment ago, right? So let me ask you this. Can you ever append a Z37 outcome of delivery code or a Z3A weeks of gestation code to an abortive outcome? Take a guess. The answer is a hard no. Seriously, this is a super common error we see in audits all the time, so let's bust that myth right now. The guidelines explicitly state that Category Z3A for weeks of gestation is simply not applicable to pregnancies with abortive outcomes, elective terminations, or postpartum conditions. And exactly like we learned with ectopic pregnancies, those Z37 outcome codes are reserved for actual deliveries. Keep those Z codes entirely off these specific claims. Okay, let's move into our final and honestly trickiest section, coding post-abortion complications. So Category 08 is designed specifically for complications following an ectopic pregnancy, a molar pregnancy, or an abortion. Think of it as a safety net. It catches specific complications like sepsis or endometritis that just aren't built into the combination structure of your primary 000 to 007 code. The ultimate question you have to ask yourself every time is this: when is 008 just a supporting character, and when does it become the star of the show? Let's model an if-then scenario to clear this up, comparing a patient's initial abortion care visit against a subsequent readmission a few days later. During that initial encounter, if a complication pops up that isn't already captured by the primary abortion code, 008 acts as a secondary support code. But if the patient is discharged, goes home, and comes back later purely to treat a delayed complication, well, that hierarchy flips entirely. To put that into perspective, in the case of an initial visit, slot number 1 goes to 003.4 for an incomplete spontaneous abortion. Because there's a specific infection documented, slot number 2 gets 008.0 to capture that extra complication. But if that exact same patient returns 5 days later, specifically to treat post-procedure sepsis, Category 008 steps up to the plate. For that readmission, 008.0 claims slot number 1 as the principal diagnosis. So remember, the clinical context of the admission completely dictates your sequencing priority. So if your next chart features a readmission for a post-abortion complication, will you know exactly who gets slot number 1? Mastering these hierarchies is what separates an okay coder from an exceptional one. It ensures compliance, and more importantly, it prevents those costly denials. That wraps up this explainer for part 55 of our series. If you found this helpful, please hit subscribe, drop a like, and share this with your fellow coders. Join me next time for part 56, where we'll decode the really intense guidelines surrounding gestational hypertension, preeclampsia, and HELP syndrome. Until then, keep coding with confidence.